Hello friends. Hello friends. Today we will discuss rare disease evaluation and genetic testing in this conference. So what is a rare disorder? Definition of rare diseases is variable as per WHO less than 1 per thousand, US less than 6.4 per 10,000 and in European Union the cutoff is 5 per 10,000. But there is no uniform definition in India and the national policy of rare diseases was framed and came into effect in 2021. Most of these rare disorders are genetic disorders and up to 50 lakhs are given to the patients under NPRD in different categories. So, what is the burden of rare disorders in India? A publication from Dr. Seth Center found out that of 3294 patients, over 300 disorders have been identified, and common founder mutations were identified in disorders like Tay-Sachs disease and MPS 4A. This analysis included neuromuscular disorders, metabolic disorders, including lysosomal storage disorders, hematological disorders, and other disorders. So the burden will vary depending on the type of the center, since there can be referral bias also for some centers. So how to diagnose these rare disorders? First, we make a clinical diagnosis on the clinical features from head to toe examination. Then we confirm the diagnosis by doing a lab testing. So as in case of Apert syndrome, it is a craniosynostosis syndrome with small head, fused sutures and mitten hands and feet, and it can be diagnosed by doing a Sanger sequencing for common mutation. So, the clinical diagnosis involves complete clinical evaluation, looking for skin, dental, hair findings, which can aid in making a diagnosis, X-rays and imaging studies, cardiac, renal, and ophthalmic evaluation. So, coming to case scenario, cleft lip palate. So, this is a common isolated malformation, but when cleft palate is there, it can also be syndromic. So, Master P, 3 months male, presented with multiple malformations and to the OPD, and then was admitted to the genetic ward. And this child was the only child with birth weight of 2.8 kg and noticed to have cleft lip and palate since birth. There was no other history in the perinatal period. So the child was first admitted in the emergency, and because of respiratory distress, possibility of heart disease was suspected. 2D echo revealed a large VSD with overriding of aorta, PDA, duct-dependent circulation, and he was planned for operative intervention, BT shunt at 3 months of age. So he had recurrent episodes of respiratory distress, noisy breathing, initially fed through dropper, then given feeding through long nipple since date of life 7. So in anthropometry, it was relatively preserved. So he had cleft lip and palate, bilateral complete cleft lip, midline cleft palate, preaxial polydactyly in the right hand, and some overriding toes and deep set eyes. So respiratory examination showed bilateral conducted sound, suprasternal subcostal retractions, pansystolic murmur in the right parasternal area, and a systolic murmur in the pulmonary area. So we have in the database a term delivery noticed to have cleft lip palate at birth, also had preaxial polydactyly, retrognathia, and identified to have cardiac defect. So in these possibilities, kept are DiGeorge syndrome, Church syndrome, and other single gene disorder. If it is a polysyndactyly, we can think of GLI1 or GLI3 related disorders also. So there can be also chromosomal deletion duplication in selected cases. So in cleft lip palate epidemiology, most patients are male, 60%. There can be midline cleft lip, bilateral cleft lip, and associated cleft palate, or only isolated cleft palate. So isolated cleft palate is also likely to be syndromic. So there are many genes identified: CTNND1, plaque HA7, plaque HA5, and CDH1. And chromosomal causes include DGeorge and XP22.23 deletion. So in patients with bilateral cleft lip palate, we have identified EEC syndrome, in which TP63 mutation was found, branchioculofacial syndrome, in which TFAP 2A mutation was found, and CHARS syndrome in which CSD7 mutation are found. However, all CHARS syndrome, we cannot identify the genes since some of the genes are unknown. So coming to skin manifestation, that is cafe au lait spots. In many patients, these cafe au lait spots are identified, and these are brown, coffee-colored pigmented lesions over the skin. And if more than 5 mm in number or more than 5 centimeter in size, they can be suggestive of underlying neurofibromatosis. So what is the diagnostic criteria? First clinical criteria is used: 6 or more cafe au lait spots, 2 or more neurofibromas, axillary or inguinal freckling, optic glioma, 2 or more lesion nodules in the eyes, bone dysplasia like sphenoid wing dysplasia or pseudoarthrosis of tibia, and first degree relative with neurofibromatosis who satisfies the above criteria. Then if at least two features as per these criteria are present, one can diagnose a patient with neurofibromatosis. So we had presented our data of NF1 patients, 29 unrelated individuals, and whole exome sequencing was done. And 20 of 29 patients, 25 had germline pathogenic, likely pathogenic variants, 5 novel and 20 known variants were identified. In addition, 7 deletions were also identified. So 7 variants were deletions, 2 duplications, and 2 were contiguous deletions. So contiguous deletions means additional genes also involved. So when we talk of overgrowth, obesity, there can be tall stature or there can be increased weight. So this includes familial obesity syndromes, familial tall stature, diabetic macrosomia, nesidioblastosis, and if there is generalized overgrowth, one can think of Beckwith-Widman spectrum, Simpson-Golabi-Behmel syndrome, Sotos syndrome. In some types, some cases, we can get segmental overgrowth. This includes Proteus syndrome, PIK3CA related segmental overgrowth, hemihypertrophy, or MCAP syndrome. Sometimes we get Klippel-Trenaunay-Weber syndrome, in which there are lymphangiomas. So when we think of obesity, infantile hypotonia with followed by increased weight gain, there can be Prader-Willi syndrome. There is also mental retardation or intellectual disability in these patients. There are some diagnostic criteria for Prader-Willi syndrome. Major criteria include infantile hypotonia, feeding problems, hyperphagia, dysmorphic facial features, and developmental delay. And minor criteria are also there, like sleep apneas and hypopigmentation in family, small hands and feet. So clinical diagnosis involves less than 3 years, 5 points, and more than 3 years, 8 points. So once diagnosed, then one has to confirm. So in overgrowth, there can be different tests depending on the type of the overgrowth. So in case of uh, if you are thinking of Prader-Willi, then MSMLPA is done, methylation studies is done, and one can identify the abnormal methylation at chromosome 15 in the chromosome 15. And in case of Beckwith-Widman syndrome, the abnormal methylation will be in chromosome 11p15. And in other conditions, the single gene disorders or segmental overgrowth cases, one has to do a next generation sequencing to identify different mutations like NSD1, NFIX, GPC3, PIK3CA, and PTEN, AKT1 in case of segmental overgrowth. So in case of hepatosplenomegaly, you have also multiple causes. One of them is storage disorders. If we think of genetic disorder, first hematological causes have to be ruled out, like thalassemia, hereditary spherocytosis, and then one can think of storage disorder. So, in storage disorder, you have Gaucher disease, Niemann-Pick disease, GM1 gangliosidosis, and they usually present with hepatosplenomegaly and cytopenia. And in case of Niemann-Pick, you can get also cherry red spot on ophthalmic evaluation. So sometimes there can be infiltrative disorders like osteoporosis and Langerhans histiocytosis, which can also present with hepatosplenomegaly. In osteopetrosis also, you can have pancytopenia, hearing loss, visual loss. Depending on the spectrum of manifestations, one can think of the type of disorder. So in this case, chronic liver disease and malignancies or autoimmune disorders are also considered. So coming to genetic testing. So what is genetic testing? Genetic testing is detection or analysis of specific changes in the chromosome level, gene level, or protein level causing human genetic disorders. So this genetic test, if it is done because of a suspected genetic condition, then it can help confirm a person's underlying condition and the chances of developing or passing of that genetic disorder. So what are the clinical applications? It can be used for diagnostic testing. The most commonly it is used for diagnostic testing. It can also be used for prenatal diagnostics. Once the mutation is identified or the variant is confirmed, then one can offer prenatal diagnosis for that particular disorder in the fetus. And then it can also be used for pre-implantation genetic diagnosis. Sometimes it is also used for newborn screening, carrier detection, and predictive testing. So we'll come to carrier detection later. So what are these tests used for genetic testing? So these can be routine test or specialized test. One of the common tests used is karyotyping and QFPCR. Karyotyping is the gold standard test for chromosomal cases. Then other tests include Sanger sequencing, MLPA, chromosomal microarray, next generation sequencing, and TP-PCR. So there are different tests, and the type of disorder we are suspecting, accordingly, we do the type of testing. For aneuploidies, we will do karyotyping. So karyotyping is a process of visual inspection of entire set of chromosomes. Karyotyping is used for detection of chromosomal aneuploidies like Down syndrome, Turner syndrome, Klinefelter syndrome, deletions or duplications if they are large deletions, or any structural rearrangement like balance translocations in case of recurrent abortions. So a 21-year old male, a follow-up patient of nephrology, was referred for intellectual disability and infertility. So karyotyping was done and genetic counseling was offered. You can see in this there are two X chromosomes and one Y, so that is XXY instead of XY. So this is extra X chromosome. This causes Klinefelter syndrome. So a case for MLPA. A 29-year-old female referred from cardiology, presented with severe aortic stenosis, had dysmorphic features like large pinna, antiverted ears, blue sclera, retrognathia, Elfin facies, suspected of Williams syndrome, and then MLPA test was done, which identified heterozygous deletion of exon 20 and 33 of ELN gene on chromosome 7q11.23. So Williams-Buren syndrome results from microdeletion of chromosome 7q. Most cases are usually de novo and identified in childhood. And in this, you can see in the report, there is heterozygous deletion on this chromosome, and this causes Williams syndrome. So P245 kit is used from MRC Holland for this identification. So MLPA can also be methylation sensitive MLPA in a newborn with large gestational age, hypotonia, omphalocene. When Beckwith-Widman syndrome is suspected, then one can detect this methylation abnormality or the deletion in case of this MSMLP, using this MSMLP for chromosome 11p15. So here you can see this there was gain of methylation or H19 DMR and loss of methylation in the other IC2 region. So this is pathogenic, causing Beckwith-Widman syndrome. So Sanger sequencing, this is also a very traditional sequencing test in which common mutations are identified. The hotspot regions are tested. In this, you can see if FGFR2 gene mutation was tested. For these three mutations, separate Sanger was done, and you can see 758 mutation, 758 mutation, 755 mutation, and the FGFR1106G2T mutation. This causes Apert syndrome and Crouzon syndrome, respectively. So chromosomal microarray, this is a recommended test for intellectual disability, dysmorphism, developmental delay, behavioral abnormalities. And in this, you can see here there is a loss identified on chromosome 13, cytoband Q12.3, and the gene number of genes involved are 41. And so this is 13q12.3 to Q13.2 region, likely pathogenic deletion, loss or deletion. So in case of next generation sequencing, usually in cases of suspected single gene disorder, skeletal dysplasia, in which multiple genes are involved, so this next generation sequencing is done. And in this, in the child with short stature difficulty in walking for past 2 years, some epiphyseal changes were there on the X-rays, and father had also bilateral hip abnormality. So, keeping a possibility of spondyloepiphyseal dysplasia, this NGS was done and it identified MAT-M3 variant causing multiple epiphyseal dysplasia. It was a likely pathogenic variant. You can see the this level where the mutation is there, C359C2T and P3onine to methionine. So, coming to genetic screening. So this genetic screening can be high risk screening, extended family screening, population screening, carrier screening, antenatal screening, newborn screening. So different types of genetic screening are there. So some disorders are common in certain populations. In those populations, such disorders are tested by carrier screening. If a disease runs in a family, couple can be tested for carrier state for autosomal recessive disorder if the proband or the index case is not available for testing. Newborn screening is done in the newborn or neonate, usually for the commoner disorders like metabolic disorders or treatable disorders in which early treatment can change outcomes. Antenatal screening is done for especially for Down syndrome or neural tube defect, but ultrasonography can detect some other abnormalities for which further testing can be done. So, coming to example of carrier screening. So, in this carrier screening, the male and female uh, partners were identified to have CEP290 variants, which were labeled at VUS, but clinical history suggested multiple cystic kidneys in the previous child. So, possibility of Meckel syndrome had been kept, and so they were counseled and told that further we can recheck or reclassify this variant later, and then we can plan a prenatal diagnosis. So similarly, another carrier testing. In this, there was a previous child with GM1 gangliosidosis confirmed by enzyme testing, and in this, the male and female were found to be carrier for GLB1 gene variants. This is autosomal recessive lysosomal storage disorder, and one variant was pathogenic, one was uncertain, but correlating with the clinical phenotype, we offered prenatal diagnosis in the family. So, nuchal translucency is important on the level 2 ultrasonography. If NT is greater than 95 percentile, in 95th centile, it is reported as increased NT. So, many other chromosomal abnormality can be identified by the level 2 ultrasound. If the nuchal fold thickness is increased, then there can be various causes, including chromosomal disorders. In cystic hygroma, a chromosomal disorder associated with is Turner syndrome. Similar cystic hygroma or cystic lesion can be seen in case of Noonan syndrome, because Noonan syndrome presents with Turner-like phenotype, and short neck or increase in NT can also be there also in case of skeletal dysplasia. So depending on the type of condition suspected, one can go for the routine QFPCR or CMA for chromosomal abnormalities, or one can go for whole exome sequencing if skeletal dysplasia or Noonan syndrome is suspected. So, prenatal diagnosis is done by invasive testing, CVS at 10 to 14 weeks, amniocentesis after 15 weeks. As per PNDT Act, MTP can be done easily till for 24 weeks of gestation. After that, it should be done through medical board. So, commonly we do QFPCR microarray. In addition, maternal cell contamination testing, which is important so that we don't give an unreliable result because of contamination. If there is a previous history of single gene disorder, then Sanger sequencing for specific variant or mutation is done. And if the fetus is found to be affected, MTP can be offered. So ultimate decision of the termination of pregnancy or continuation of pregnancy, even if fetus is affected, is with the couple. So counseling is non-directive. So in this case, there was previous child with DMD with exon 50 deletion. CVS was done at 12 weeks of gestation and set for definitive testing. So MLP was performed and deletion of this exon 50 was identified. So this indicates that fetus is affected with DMD. Accordingly, post-test counseling was offered. So for SMA also we can do MLPA for prenatal diagnosis. Nowadays we also do carrier testing for SMA in some selected couples because SMA is a common neuromuscular disorder. And in SMN1 gene, exon 7, exon 8, if are deleted, it causes SMA. And if there is SMN2 duplication found, copy number is increased for SMN2, then it can be protective and the phenotype can be less severe, like type 2 or type 3. So Sanger sequencing can also be used for testing, and in this you can see call for A4 gene was tested because there was a previous history, and you can see this heterozygosity for call for A4 gene. So accordingly, if it is a dominant disorder or a recessive disorder, so in the fetus this heterozygosity was identified and counseling was done. So prenatal CMA can also be done in a child, a baby with corpus callosum agenesis, echogenic focus in the heart found on ultrasonography. Microarray was done. A low resolution microarray is usually done for prenatal diagnosis. And in this you can see 3p26.3 deletion was identified. And this is the size of the deletion, 959 kb, and this includes the gene CNTN6. So, if it is a known deletion, pathogenic deletion, then termination of pregnancy can be done. So, what is importance of genetic counseling? As I told, pre-test and post-test counseling are done. Psychosocial and ethical implications are to be considered. In less educated, less receptive couples, sequential information can be provided. Decision for testing subsequent prenatal diagnosis should be taken by informed couple after proper counseling. In case of next generation sequencing, unexpected results can be done there, which can cause undue anxiety. And so, family pressures, financial issues should be considered, sorted out, and different settings can be there for the counseling before a ultimate decision. So for Fragile X syndrome, if you want to counsel, there can be pre-mutations, full mutations. First, diagnosis index case is established by molecular testing, TPPCR. Then a mother is a carrier, and repeat size count can be noted, and the risk of recurrence is based on the mother's repeat count. Directly prenatal diagnosis can also be offered if previous history is there or mother is tested to be positive. And then screening of the siblings and female relatives of the mother are also recommended for expanded family screening. And if there are full mutations, then the the male child baby will be symptomatic, and so they can terminate the pregnancy if they are doing a prenatal diagnosis. So we did this walkathon in February 2025 for rare disorders. Then, since there is a significant burden, so proper NGOs are there for different disorders, and if they meet this affected persons attend these meetings, then this burden can be further reduced. This burden is more for rare diseases rather than for common diseases. This was a rare disease meet in 2019 in Delhi, and this is the rare disease meet in 2020. Thank you for patient listening.